When we talk about mood disorders, we're really talking about a kind of diagnostic architecture. And to understand any complex structure, you have to start with the fundamental components, the actual bricks and mortar. That's what we're going to do today. We're going to break down these disorders into their core building blocks. So here's our plan. First, we're going to master the 4 essential diagnostic building blocks. Then we'll see how they're used to construct the bipolar spectrum. After that, we'll define the depressive disorders, and we'll finish up by looking at the critical boundaries that separate these diagnoses from one another. So that brings us to the central question. How are these conditions actually defined? Well, it's not as simple as looking at how someone feels right now. A precise diagnosis really requires a longitudinal view. It's almost like a forensic examination of a person's entire life history, searching for the presence or the absolute absence of very specific, clearly defined mood episodes. Okay, let's begin with those foundational units. Every single diagnosis that we're about to discuss is built from these 4 episode types. You have to master these first because they're the key that unlocks the entire diagnostic system. First up is the major depressive episode, or MDE. Now, for this diagnosis, you need 5 or more of 9 specific symptoms, all happening within the same 2-week period. But here's the crucial part. One of those symptoms absolutely has to be one of the 2 anchors, either a depressed mood or a profound loss of interest or pleasure in things, a state we call anhedonia. Second, we have the manic episode. This is a very distinct period of abnormally elevated or irritable mood, and it's always paired with a significant increase in energy or goal-directed activity. It has to last for at least 1 week, unless, of course, the person has to be hospitalized. And here's the absolute key differentiator. A true manic episode causes marked impairment in functioning. Our third building block is the hypomanic episode. Now, the symptom profile here is identical to what you see in mania, but the duration and the severity are critically different. A hypomanic episode lasts for a minimum of 4 consecutive days, and, this is by definition, it involves no marked impairment, no need for hospitalization, and no psychotic features. It's a noticeable change, for sure, but it is not a debilitating one. And finally, our 4th piece is the mixed features specifier. Now, you have to understand, this isn't a standalone episode, it's more like an overlay. It applies when a person is in the middle of a full manic, hypomanic, or depressive episode, but at the same time they're experiencing at least 3 symptoms from the opposite mood pole. This signals a much more complex and, frankly, often a higher risk clinical picture. All right, so now that we have those 4 building blocks firmly established, we can start to actually assemble them. Let's see how they create the architectural structures of what we call the bipolar spectrum. Let's start with bipolar I disorder. When it comes to making this diagnosis, you need to know that there is one single, non-negotiable cardinal rule. Everything, and I mean everything, hinges on this one historical fact. And this is the rule. The lifetime history of just one full manic episode is all that is required for a diagnosis of bipolar I disorder. That's it, 1. Now, while major depressive episodes are very common in people with bipolar I, they are not actually required for the diagnosis. That single manic episode is the sole prerequisite. This really shows you the absolute firewall that exists between bipolar I and bipolar II. Bipolar I is defined, as we said, by that lifetime history of a manic episode. Bipolar II, on the other hand, requires something different. It needs a history of at least 1 hypomanic episode and at least 1 major depressive episode. But the critical exclusion rule for bipolar II is that there has never, ever been a full manic episode. That's the line in the sand. So what about mood instability that doesn't quite reach the level of a full episode? Well, that's where cyclothymic disorder comes in. You can think of it as a chronic, subthreshold form of bipolary. For at least 2 years, the person has numerous periods with hypomanic symptoms and depressive symptoms, but they never meet the full criteria for a complete episode. It's a persistent, fluctuating state. Okay, that covers the bipolar spectrum. Now let's pivot and construct the depressive disorders. And the defining feature of this entire family of disorders isn't what is present, but rather what is explicitly absent from the person's history. Major depressive disorder, or MDD, is defined pretty simply. It's the presence of 1 or more major depressive episodes. But the absolute rule, the diagnostic boundary, is the complete and total lifetime absence of any manic or hypomanic episodes. If that history exists, the diagnosis simply cannot be MDD. Next, we have persistent depressive disorder, which you might also know as dysthymia. This has a totally different architecture. It's not about those discrete, severe episodes you see in MDD. This is a chronic, lower-grade depression. It's characterized by a depressed mood for most of the day, on more days than not, for at least 2 years straight. Chronicity is its absolute defining feature. So now that we've defined all the individual disorders, let's synthesize these rules. We're going to put everything together into one coherent framework by really examining the critical diagnostic boundaries. This table really summarizes the entire diagnostic logic. Look here. Bipolar I requires mania, period. Bipolar II requires both hypomania and depression, but it prohibits full mania. MDD requires depression, but prohibits any history of hypomania or mania. Then you have cyclothymia, defined by its chronic subthreshold symptoms, and PDD, defined by its chronic low-grade depression. You see? Each diagnosis is defined by what is required, and just as importantly, by what is explicitly prohibited. And that brings us to what is probably the single most important rule in this entire diagnostic system. This statement right here is the bedrock of the differential diagnosis between bipolar and unipolar depression. It is an absolute, completely non-negotiable boundary. Now, you might think this intricate diagnostic architecture is just some academic exercise, but it's not. These precise boundaries exist for an incredibly critical reason. So that leaves us with a final question to consider. Why does achieving this level of diagnostic precision matter so profoundly for treatment pathways, for prognosis, and ultimately for a person's clinical outcome?